Good morning, everyone. I would like first to thank the organizing committee for inviting me to be here. And I'm going to give a brief historical overview of what has been going on heart failure in sub-Saharan Africa. We have published a paper some years ago, about 7 years ago, analyzing what has been published till that time about heart failure in sub-Saharan Africa. And we showed 11 studies that have been published from 1957 in Zimbabwe. Most of these studies have been done in South Africa, but as you can see, the main causes of heart failure at this time were rheumatic heart disease, hypertensive heart disease, and dilated cardiomyopathy, so the three first rows. Also important, Uganda, as you remember, was one of the points where endomyocardial fibrosis has been firstly described, so it was importantly prevalent in Uganda, and cor pulmonale has always been present in South Africa. These are clinical series, but also it is important to stress that most of these studies have been done in the pre-echo phase, so without the confirmation of the echocardiography of these cases. In the same paper, we had also showed that we had 4 necropsy series done in Africa from as early as 1946, and here also we can see that the same causes of heart failure, like rheumatic heart disease, hypertensive heart disease, cor pulmonale always in South Africa, and endomyocardial fibrosis in Uganda. A little bit later, some months later, Bongani Mayosi published this paper in The Heart, and he has put everything together. So he presented a combination of 12 studies done in Africa previously from 1957 to 2005 and involving 4,500 patients around. And what Bongani showed is that there are mainly 3 causes of heart failure: hypertension, cardiomyopathy, and rheumatic heart disease. Very few cases, only 2% of cases due to ischemic heart disease at that time. And pericarditis and cor pulmonale were also very common causes of heart failure in sub-Saharan Africa. So we concluded there are 3 major trends that are evident from this analysis. The first one is that the vast majority of heart failure cases in sub-Saharan Africa are due to non-ischemic causes, with rheumatic heart disease, hypertensive heart disease, and cardiomyopathy accounting together for more than 75% of the cases. The second conclusion is that ischemic heart disease remained at that time uncommon, with no apparent increase in its contribution to the case of heart failure over the past 60 years. And the third is that the contribution of cor pulmonale and pericarditis to about 20% of cases of heart failure reflects the continuing impact of tuberculosis on heart disease. But this was the background. Then a landmark study has been developed in Johannesburg, the heart of Soweto, and everybody's aware of this study. This is a big study. As you know, Soweto is a huge community around Johannesburg with more than 1 million people, and is served by a single hospital, the Baragwanath Hospital, the biggest hospital in the world, and there are more than 5,000 patients that are seen every year with cardiac pathology by this hospital. And the idea was to do a detailed registry of all the novel cases that showed up in this hospital. So the Heart of Soweto study involved several studies: community surveillance, tertiary care registry, primary care registry, interventional trials, and IT-based education projects. But I'm going just to show you the results of this tertiary care registry that is in what we need to show here about heart failure. So during this year, 1,593 patients have been seen in the hospital of Baragwanath, and of these 1,500 patients, 844 were due to heart failure. And what were the causes of heart failure? So we had 32% of cases secondary to dilated cardiomyopathy, 29% hypertension. As I show you before, right heart failure is extremely common in Johannesburg because of high altitude and probably tuberculosis and all the workers of the mines, etc. Only 8% of the cases are secondary to ischemic heart disease, and 7% are valvular cases. In this paper that Simon and my co-chair published in the Circulation in December 2008, he showed that except for ischemic heart disease, which was expected that the men had much more than women, hypertensive heart failure was more common in women. Women were more common and also were more obese, but idiopathic dilated cardiomyopathy and valvular heart failure and right heart failure were equally represented in both sexes. This was a landmark study done in a single center that brought a lot of information about heart failure in Africa, and it was really a big work of Karen Sliva, Simon Stew, and several other people. But then we have published about 2 years ago a study which is a multi-center study. This was a registry to look for the etiology, the treatment, and morbidity and mortality of heart failure in 9 countries in Africa. And as you can see, the countries are very well represented in Africa. We have South Africa, Mozambique, Kenya, Uganda, Sudan, Ethiopia, Cameroon, Nigeria, and Senegal. 13 centers in these countries, university centers, and the patients have been followed for 6 months. I will speak later this afternoon about the results of the thesis, but let me just show you that in terms of the results, the major results, the mean age of the patients was around 52 years. About half of them were women, most of them were blacks, and the mean ejection fraction was 39.5%. And we found systolic dysfunction in about 70% of these patients. Related to etiology, we have classified in old and new cases of heart failure, and as you can see, the major etiology was still hypertension. And ischemic heart disease just contributed about 8% of the cases. Rheumatic heart disease, 15%. Idiopathic dilated cardiomyopathy, 14%. Peripartum, 7.5%. Pericardial effusion and tamponade, about 5%. HIV cardiomyopathy, 2.4%. And endomyocardial fibrosis, 1.3%. But this was not the only thing that has been done in Africa during these days. This thesis has been able to create a network of centers in all these countries, and nowadays with more countries added. And this allowed us also that these countries have been able to participate in international registries run outside Africa. So this has created the embryo of small, excellence centers, and the result is that Africa has participated in the Interheart, that you all know, with a lot of cases, in the Interstroke, with more than 1,000 cases, and Interstroke has recently finished and is going to be published, the final paper, in a few months. Also in the RELY, which is a registry of atrial fibrillation cases, with more than 1,000 cases coming from Africa also. And from all these centers that have participated, or most of the centers that have participated in the thesis. But not only international, even African projects have been developed during these last years. And when I say African projects, I say that they are African because they have been born and done in Africa and with an African budget, which means very little money. Let me just stress 2 big projects that papers have been published very recently. The Remedy, which is a registry of more than 3,000 patients with rheumatic heart disease that have been followed for 2 years. This is the paper of the basic characteristics of the patients that have been involved in the Remedy. And the second, that has also been published in the last months, is the IMPI trial, which is the result of the use of prednisolone in the acute and subacute phases of the tuberculous pericarditis, and I think that all of you are aware. Other projects, most of them local, national projects. There is one that I would like to stress from my good friend Professor Oga, done in the south of Nigeria, and you have 3 posters in the room of the posters related to this project, and a more recent one from our friends from Tanzania, Abel Makubi, that has also been published in the Heart just a few days ago. So let us put everything together and say that 30 years ago, most of the knowledge we had about cardiovascular diseases in Africa were extrapolated from studies done in the so-called Afro-Americans. But now we have really very good data. We need more, but we have very good data on heart failure, peripartum cardiomyopathy, endomyocardial fibrosis, rheumatic heart disease, tuberculous pericarditis, atrial fibrillation, acute myocardial infarction, and stroke. During this last, let us say, 5-10 years, several papers have been published, and 2 different numbers of the heart, 1 number of the circulation, and the recent number of the progresses in cardiovascular diseases were dedicated to cardiovascular diseases in Africa, and mostly written by African doctors. So I would say that the positive points of the activity in these last years is that an enormous amount of new knowledge has been added, both in terms of epidemiology, but also in terms of physiopathology, morbidity, mortality, and treatment of the most common diseases in Africa. An embryo of centers of excellence was developed. But there are also negative points in my point of view, is that most of these centers are still the result of a one-man show, and there is no economical sustainability of these centers that we have to look for. We also do not have data on incidence and on mortality in Africa. If you go to look to the global burden of disease, most of the data is just guessed from small studies. So we have to establish low-cost, high-quality surveys because they be highly informative to give you this data. A comprehensive training program in surveillance theory and methods could be implemented in many additional countries. Centers of excellence should be created for scientific training and research. Capacity building can now make use of telemedicine and internet-based programs, which, if properly balanced with bilateral exchanges of faculty and trainees, can reduce costs and enhance sustainability. Just to show you a small example of the papers that have been published with clinical research relevance for Africa from 2001 to 2011, you can see that the total amount of papers has increased a lot, but not only this, but papers with a first author from Africa, which is this higher part of the column, is much bigger nowadays, and also with co-authors from Africa, which means that there's a big change in terms of research and in terms of the authority of the research in Africa. So finally, I would say that what we need strong epidemiological data on community incidence, morbidity, and mortality of the main cardiovascular diseases. We need intervention studies that should be developed to find ways to halt the increasing burden of risk factors on a feasible way, and the research centers need to become stronger and economically and scientifically more independent. And I thank you very much for your attention.
Thank you, Albertino. If you want to stay there, we might have some questions. You were... Okay, Albertino doesn't listen, so do we have any questions from the floor? Yes? Could we get a microphone to the front, please? I will. I do notice when the lights went up, there were more people in the room than there were when the lights went down. You know, it was a magic trick. Okay.
Thank you very much for this very comprehensive and excellent presentation. In reference to the Heart of Soweto study, and the results, the very interesting results that you obtained, can these results be extrapolated to the rest of the South African population?
So that was about the...
Yes. No, you can answer, because he's the co-author of that research.
Okay, so I'll answer that on behalf of the Heart of Soweto study. There are some differences, variations in regions, and you're going to hear from Dr. Ogar, who actually has done some comparisons between the southern Nigerian heart failure population and that in Soweto. But the major trends of the contribution of hypertension, a large component of right heart failure, also with a low contribution for ischemic cardiomyopathy, can in actual fact be extrapolated to the rest of the South African population, particularly in epidemiologic transition, and indeed to the wider Southern African population. And I say this because I will show you some data looking at the two different trends around the age of non-communicable forms of heart disease and communicable. There are two divergent trends, and we're at the crossroads. So it just depends where a community is at. Is it at a point of epidemiologic transition, or has it already reached a point of no return in terms of urbanization and adoption of those things that we know drive a more ischemic form of a non-communicable form of heart disease? Please.
Thank you. The population of adult congenital heart disease is growing everywhere in the world. You did not mention anything about congenital heart failure patients.
Sorry, can you say that again?
The population of adult congenital heart disease is growing everywhere in the world, but you did not mention anything about congenital heart failure patients.
Yes, congenital heart disease has not been included because, as you know, these studies have been mainly done in adults first. Second, there are very few centers doing surgery in congenital heart diseases, and even if there are some few patients with congenital heart disease that survive till the age of adult, they are probably not very important contribution in the heart failure situation in Africa, because most of them, they died in the early years of life.
And you mentioned about the epidemic of rheumatic heart disease and cardiomyopathies. Do you see a combination of rheumatic heart disease with cardiomyopathies?
So rheumatic heart disease and cardiomyopathies.
A combination of them. One of the issues that is very interesting is that, as you know, for example, peripartum cardiomyopathy, which is extremely common in Africa. And by definition, it's a heart failure without a previous heart disease. But when you have a huge prevalence of rheumatic heart disease, those ladies can also develop systolic dysfunction immediately postpartum, and they can have the both situations. I mean, they have a basic rheumatic heart disease, but they developed a clinical picture of peripartum cardiomyopathy. Also, HIV, it's another thing that happens together with rheumatic heart disease. HIV, it's extremely prevalent in several African countries, and I can't remember any other common association between these situations.
But how do you differentiate? Because although it's rare to have systolic dysfunction and rheumatic heart disease, especially most prevalent is mitral stenosis.
How do you differentiate?
Between systolic dysfunction and?
If you have a combination,
well, we have
how do
done
you
echo.
differentiate whether
No.
systolic dysfunction is because of the peripartum or because
Sure.
of the mitral?
I mean, we use the criteria, the normal criteria. We have done echo to all the patients, and we have done the Doppler to all the patients. So we have used the Doppler criterion for diastolic dysfunction.
I am Dr. Khalid from Sudan. I work in a remote hospital outside Khartoum. We see a lot of cases with acute heart failure. with no obvious etiology. We assume that most of these cases are due to acute viral myocarditis with very bad outcome. The mortality is almost 100%. I am not sure. Is there any possibility for alternative diagnosis, or most probably they are due to viral myocarditis? And the other question, is there any special advice about the management of such cases? Thank you.
The second question. Well, can you repeat the second question, please?
The second question about the management of cases of acute viral myocarditis.
The management of these guys.
I wonder, I mean, it's the diagnosis of viral myocarditis in our setting, it's a little bit difficult. I mean, if you see a patient with acute heart failure and who has dilatation and systolic dysfunction, maybe you should put it as a dilated cardiomyopathy, either primary or secondary to hypertension or peripartum, or, well, in Sudan, probably alcohol is not a very common case of dilated cardiomyopathy. But I would say that it's extremely difficult to diagnose a myocarditis or acute heart failure secondary to acute viral infection in our settings. The idea that I have is that there are only two ways. I mean, either they cure, and we see some in children, either they cure and they have a normal systolic function 6 months after, or if it is extremely severe, they die in the acute phase. Or the second is they evolve to secondary dilated cardiomyopathy, but it's very difficult to diagnose without with the chances that we have to do it. Yes.
Well, the question of Dr. Khalid about this acute myocarditis, we commonly see it there in Sudan. There are two things which are very important in the diagnosis. Apart from being acute illness, it's always there is a febrile illness before it, 2 or 3 weeks before, or a month before that. You got clear history about that, and then you get this acute illness of heart failure with significant ECG changes, T-wave inversion throughout all the 12 ECG leads. And these people, strangely enough, they recover. It's start as a cardiomyopathy that as the years go on, it recovers. They recover their ejection fraction. Quite a few of them do that. Thank you.